There's 540,000 people over the age of 65 in this country. Most of them are absolutely, as we discussed this morning, most of them are fit and well, absolutely having a fantastic life and enjoying themselves. But as you get into the later years in life, obviously medical conditions, comorbidities start to kick in, and a lot of them are living, most of them are living at home, 95% are living at home. And from the point of view of geriatric or the older person resuscitation, the resuscitation in an older person is a little bit different, and I think if you're going to apply the principles of paediatric training for paramedics, adult training, I certainly think that there's scope to do it for the older person also.
Great. You raised a point on the stage. You made a difference between dementia and delirium. Yeah. Would you mind speaking a little bit about that?
Yeah, this is so important actually. It really is so important. Dementia is a very common condition. It's a very easy way to remember how common it is. If you take the age groups from 60 plus in 5-year little increments, so 60 to 65, it's about a 2% prevalence. So 2% of the population will have it. Every 5 years it doubles. So you go to 65 to 70, that's 4%, and then it goes to 8%, and then to 16% and 32%. So dementia, which is a progressive, slow condition, it's a nasty condition, progresses slowly over time, can cause people to be very confused and disorientated. Delirium is an entirely different condition. It is an acute onset which happens over hours, sometimes even minutes, but hours to days to weeks, and it is due to a physical illness that if it's identified early enough and treated early enough is reversed. If it's not treated, it may stay. The rot might set in. So when someone has delirium, there needs to be an aggressive search for the cause and obviously tease out the cause and treat it. And the gratifying thing is, in 85% of patients with delirium, you restore them back to absolutely normal function and brain function again. It's really important.
For me, one of the key things I took away from listening to yourself and Dr. Killian as well, who was on the stage also, was the question was raised, do every patient in a nursing home, should they go to hospital? You gave your story insight when you started to get involved in geriatrician treatment, and you were talking about, people came and you fixed the problems, and we have problems, so it's fixable, I mean, from that, what's your opinion on that?
Yeah, I mean, I think Killian answered that very well actually today, and he's quite correct to say it can't be a no or a yes to that actually. So there are patients who would, for example, and Killian gave the example this morning, have fallen in a nursing home and break their hip. They absolutely need to have their hip replaced or at least fixed, because the pain associated with it is absolutely terrible. Someone might have a gastrointestinal bleed, which is sudden and dramatic, and they again might need to have treatment for that. Or in addition to that, might have a heart attack out of the blue and actually are up and about and independent in the nursing home, so they should be treated. Then there are patients who are nursing home who become frailer and frailer and frailer. Sadly, their existence might be bedbound, no speech, no recognition of the people around them. And the mode of death, the invariable mode that they will die with is a pneumonia. And therefore, that is the natural end to their life. And if a patient like that becomes unwell, it's going to happen, so it's possible to pre-plan this. What are we going to do in the event of this patient becoming unwell? And I think there are on occasions patients who are probably inappropriately moved from the warmth, the comfort, the excellent care of their nursing home to a hospital when the treatment almost certainly is not going to add anything to their life at all. And I think that I think it's important that we put in place mechanisms to do that. And actually, it's not. A lot of other countries, particularly the States, are doing this actually, and having conversations before it arrives. Mm-hmm. Having conversations with the nursing home, having conversations with the doctor, having conversations with the family. What are we going to do if this happens?
It's day one, my first day in the ambulance. I meet you in the hospital. Give me your pearls, your hips, your tips, your wisdom from my career.
For an older person?
For an older person.
I would think, in fact, actually, one of the things that we used to say about geriatric medicine, actually, and it probably is the number one tip, actually, always take a thorough history, and always listen to the relatives. Particularly because we mentioned earlier on that patients often can get confused and be confused, and therefore the story might come from the family. And listen for the story, because it always comes out. A very good thing, if we were wondering about a baseline, and I think it's very important when you're trying to establish someone's baseline, is the question, and I remember Killian teaching me this in the 90s, to say, ask them, when did they last go get their pension? And that kind of marks the time actually when they were independent.
Very good. Dr. Mike Connor, thank you very much for joining us at the EMS Gathering 2017. We hope you enjoyed a few days. Absolutely. And we'll see you in the future. Thanks a lot.
Thank you very much.